The broadcast is now starting. All attendees are in listen-only mode.
Okay. Hello, everyone, and welcome to Coaching Call 9, the pharmacy role in OAT, improving outcomes through better communication. My name is Rana Jarnabi, and I'm your moderator this afternoon. We have George Budd today with us to speak to us about this topic. I'll hand it over to him to introduce himself and present to us. But before I do that, just please familiarize yourself with the control panel you have, and so you can actually type in your questions or actually raise your hand and I can unmute you and you can ask your questions. I'll keep everyone muted for now just to avoid any background noise, but let us know if you have a question. And George is more than happy to answer your questions as we go. So George, I'll hand it over to you.
Sure, thank you very much, Prana. Hi, everybody. Thank you for this opportunity and the invitation to come talk to you about the role of a pharmacist in opioid use disorder. I'm a pharmacist. I'm an independent pharmacist, and I currently am in the fellowship, in the addiction medicine fellowship at the BC-CfE. And I've worked as a pharmacist in community settings most of my times, but I have a couple of years of residency and clerkship when I was doing my PharmD in hospitals. Hospital was in mental health, actually, when I first came out of school. I believe that the pharmacists are an integral part in care provided to patients overall, and in particular for patients in opioid use disorder treatment programs, especially because in most cases they get to see those patients every day. So it's an excellent opportunity for pharmacists to interact with the patients, see the patients, see what's happening, report on progress if needed within the care provided, the care circle that is included in their care that they're receiving. Just looking here with this. So I have been asked to present on a few topics. So the objectives that we will talk about are, I've been asked to present on what is it the pharmacist does every day and talk about the workflow and how are drugs entered on PharmaNet. You have a question about the collaboration with pharmacists and how can we build on that. Also about the notification process for missed doses and how that is. Also how we can work with pharmacists and other health allies to improve on the system and the care provided to the patients. How reliable is PharmaNet? And we'll talk about PharmaNet as a database for the information that is put in. And I will also talk about the role of the ministry and the participation agreements between pharmacies and the ministry to provide the care they provide. So if we were to start with a day in the life of a pharmacist, depending on the volume of patients the pharmacist provides, it could be a few patients, it could be more than that. The ministry used to have a limit on the number of patients that received. At that time was only methadone. And then the pharmacy would have to ask for an exemption to receive more, but those things have all been removed. So a pharmacist works day in and day out with those patients, like I said. So if we were to describe a pharmacy down in the core of downtown Vancouver, where there's a larger than usual number of patients, that are also polypharmacy, so they're receiving their opioid use disorder medication, whether that is methadone, Suboxone, or sustained release or morphine. There's also the injectables that I'm not going to be including in this presentation. However, there's also a number of other medications that patients may be on. So a pharmacist has to, by law, they're required to store all their narcotics in the safe. So we used to prepare medications ahead of time and so on. I'm assuming now things are harder to do that because there will be no space in the safe to store all those medications. So the reason sometimes pharmacies will put especially the methadone or Suboxone first thing in the morning on PharmaNet is a workflow issue, because you want to make sure that this patient is also well looked after. They have enough time to interact with the patient. By the time they pull the drugs out of the safe, prepare it, process it on PharmaNet, and the other thing is, PharmaNet is an older system now. Depending on how many medications this patient is on, that transaction sent to PharmaNet for adjudication and back could take a while. If the patient is on multiple medications on daily dispensed and so on, you can imagine how heavy that profile is to go and come back. PharmaNet is or was built as a billing tool. And then they realized they can use it for clinical purposes, and pharmacists now use it, or they have been using it, in all fairness, for drug evaluation, usage, and all those beautiful things that pharmacists do. However, initially, the purpose of it was to put the drug through for billing purposes. There's no function for pickup. Picked up. But that's no different than any other chronic medication that a patient orders ahead of time. They can order it in, the pharmacy processes it, puts it on the shelf, and when you come in, you pick it up. The pharmacy has done their job at reviewing PharmaNet, which is the requirement, is that a pharmacist must review the medication history of the patient prior to dispensing. It doesn't say how far before. However, if the patient ends up going for another prescription in the meantime, that second pharmacist that fills that prescription has the obligation on reviewing to make sure that it is suitable, it's a good drug, that it's not going to cause any problems, and so on and so forth. And pharmacists have an obligation also by legislation to deal with any therapeutic issues, or as we call it, therapy-related problems prior to dispensing the medication. Oh, I guess I forgot to move my slides. I'm sorry about that. I'm not very good at that. The other thing I wanted to talk about is we don't want patients to just sit around and wait for their medications while they can be served timely, while other people may be just coming in and out. So again, I understand the question. I think the question is, why are the medications showing up on PharmaNet so early in the morning? And in most cases, it's just a workflow to make sure that the prescription has been processed, the pharmacist has done their job to review the history and so on. The drug has been prepared and is ready for the patient to be looked after. I'm gonna talk about the oral medications for opioid use, and as Suboxone has moved up to be the first line of treatment, we'll talk about that one first. I would like to mention that I was with the College of Pharmacists for 12 years, and I was part of developing the guidelines for methadone. The Suboxone and the sustained-release oral morphine were done after my time. However, they're very similar in the dispensing and the missed doses and so on of how they should be handled, or what the expectations of pharmacists are under Policy 66. And again, if you need further information, you can just log into the College of Pharmacists website under resources, and you will find on the right-hand side the Professional Practice Policy 66 with its different parts. Now, for Suboxone or for buprenorphine naloxone prescriptions, the pharmacist must be present to release the prescription. That is a clinical function that cannot be delegated to anybody else other than the pharmacist. And be aware that this is the word that is used here, or the wording used here is that the pharmacist has to be present to release the medication, because it's a bit different in cases of methadone and sustained-release oral morphine. If the prescriber orders the prescription to be daily dispensed, here's the caveat that you need to be aware of, is that the pharmacist is not required to observe the patient ingest the buprenorphine Suboxone. It's different than the methadone. The only expectation under Policy 66 for Suboxone is that the patient has to be observed by the pharmacist placing the pill or the tablet under the tongue. That is the extent of expectation set by Policy 66 for daily witness ingestion by by a pharmacist. Again, the other difference in Suboxone requirements or buprenorphine and naloxone is that if carries have been ordered, the first dose is not required to be witnessed either, which again, it's different than the methadone and the sustained release oral morphine. But the one common thing has always been if the patient misses the dose, they cannot make up for that dose. That dose cannot be made up for. Methadone. Methadone historically was under the federal government, and then the provinces took over, and from there are a lot of progress between the College of Pharmacists and the College of Physicians setting the rules around it. However, in this case, if we were talking about the pharmacist expectations under Policy 66, the pharmacist is expected to be directly observing the patient ingest the medication in this case. So in this case, the pharmacist is expected, and they also receive, unless things have changed since I've left, but they receive a payment for that monitoring fee for monitoring the pharmacist, for the patient, ingesting the entire dose. In this case, also, it's different with the methadone versus the buprenorphine naloxone, because if the dose has been ordered for take-home doses, the first dose, and that's the default, the first dose has to be witnessed by the pharmacist, unless the prescriber writes on the prescription that no witnessing is required, and then it's up to the physician or the prescriber, with all due respect to other prescribers, of course, to make note of why no witnessing is required, none whatsoever. However, in the case of methadone, with carries, the pharmacist is expected to witness the first dose, and then the other doses of methadone are individually measured and packaged and handed out to the patient. The other thing is, at that time when this policy was put in place, we also put in place, or the college put in place, a section about the deliveries. So, and I'm assuming, or I think from what I know, is that the Ministry of Health, the Federal Ministry of Health, Health Canada at least, was working on allowing for pharmacists to also transport narcotics. But at that time, and I'm not sure again if this has changed or not, pharmacists were not legally allowed to transport narcotics. By law, by the CDSA, only somebody with an establishment license, or a wholesaler that is, was allowed to transport narcotics. However, for clinical reasons or for patient care reasons, it wasn't uncommon for pharmacists to be taking those doses to the patients if they're not able to do it. But as a college, the college is always expected to regulate at the same level as the federal requirements, if not higher, but not less. So the section about the delivery was put back on the physician to decide, or again, the prescriber at that point, to decide if the patient has severe immobility issues that would prevent them from attending the pharmacy to get their dose. However, it was not an obligation on the pharmacist to do it if they were not doing deliveries, but then they were obligated to make sure that the patient is aware that they can do it. And the prescriber would have to sign the declaration on that prescription form saying that the patient has severity and mobility, hence delivery is required. Everybody is good? Anybody has any questions at this point?
I have a question.
Sure.
Just about the issue of mobility. I think a lot of our patients, it may not be a physical disability, but it's more mental health, agoraphobia, social anxiety, where we really have trouble keeping them on therapy because they don't get out to the pharmacy every day. Can we frame that sometimes as a severe mobility issue, actually?
Yeah, the legislation or the policy did not describe what severe immobility is or mobility is. So if that is your clinical justification that the patient has agoraphobia or social issues that will prevent them from attending the pharmacy, the pharmacist is not going to go ask why is it that the patient has. I mean, they're not obligated to police anybody else other than themselves. That answers your question?
Yep, that's great.
Now, the third drug that was added to the opioid use disorder scheme of treatment is the sustained release oral morphine. And in that case, when this was put in place, Cadian was the drug of choice, and I don't know if it is still the Cadian or not. I know there was some shortage or not, but however, I believe that has been resolved. So the pharmacist again must be present to release the sustained release oral morphine to the patient and cannot be delegated because again, it's a clinical function that the pharmacist has to do. With the witnessing, the pharmacist must be also directly observing the patient. So there you go, you see the commonality here between methadone and sustained release oral morphine, where the pharmacist has to observe. And given, of course, that they're opening the capsule and emptying it, they also have to instruct the patient not to chew and to make sure that they swallow the whole thing as it is. They give them water to wash it down, so they make sure that there's nothing left in the mouth. Again, with the commonalities between sustained release oral morphine and methadone, if the doses are to be taken or prescribed with carries, then the first dose again must be witnessed ingestion. One of the questions that came my way in preparation for this webinar was a question about collaborations and how do we develop a closer collaboration with community pharmacies and how can a pharmacist and other providers work together. As a pharmacist, I can tell you that it is an expectation of pharmacists to work with other healthcare providers for the best interest of the patient. So I'm not sure what challenges some of you may have with that, or if there are any examples of that you want me to answer of what collaboration challenges you might have. However, I can assure you that pharmacists are very open to working with us. Approachable, they're always there. You can always find a pharmacist to talk to if you have any questions. And if it's within, of course, their obligations of privacy, they will talk to you about anything that you need to know with a patient-centered approach, of course. However, if you have any examples, I'm here. I can always answer your questions. Now, I was also asked to talk about the missed doses, and I noticed the word protocol. So I'm going to split that question into two. So as we discussed earlier, pharmacists often put the medications through on PharmaNet early enough so they can just have it ready and get that part out of the way so they can spend more time interacting with the patient. However, the expectation is if the patient misses the dose, does not show up for it, that it gets reversed on PharmaNet. There's an intervention code that we use to reverse that prescription, and it should be the proper intervention code that will keep that prescription transaction on PharmaNet. If an error happens, we put an intervention code that an error happened, which removes that prescription so there's no confusion. But if the patient does not show up, that is more of a compliance. So we want to make sure that the next person who reviews the PharmaNet knows that the patient missed that dose. So missed doses should and must be showing up on PharmaNet as well. Now, if you're asking about protocol as in can a pharmacist adjust a dose for missed doses if a patient misses 1 or 2 or 3 days and what they should do, pharmacists don't have an independent authority to change anything in the prescription. So if the prescription is for 50 milligrams, it has to be dispensed as 50 milligrams. Even if the patient refuses to consume the whole thing, pharmacists are expected to do their best to adjust the dose to whatever the patient knows as in consultation with the physician, but PharmaNet has to reflect what the patient actually received. So I'm not sure if the College of Pharmacists is working on updating that part with the protocol.
So I know some of our prescribers are doing things like in the instructions putting if misses this number of days, cut dose by 50%. So are the pharmacists able to act on information like that if it's put in the instructions for the OAT?
I haven't seen that in my practice, so I'm not sure how this is done. However, whatever is in the prescription, if it's day specific, the pharmacist can follow it.
Okay.
But they cannot be an open-ended kind of,
yeah.
There's no protocol that they can just follow. There's a requirement for all oral opioid use disorder medications that if the patient misses a dose, that the prescriber has to be notified prior to the previous dose. And pharmacies still use faxes. I know the world has moved on and technology has progressed in many, many ways, but pharmacists still feel very comfortable with their faxes. Our legislation still talks about faxing prescriptions. And I know that the College of Pharmacists might be considering kind of updating or something, but I'm not involved in anything at that point, so I can't say anything about that. PharmaNet reliability. I honestly think that we're very lucky here in BC to have PharmaNet. Not every province has the luxury of having a database that has the prescriptions the patients have received. In theory, PharmaNet came in effect September of 1995. So any prescription that is filled in BC has to be put on PharmaNet. Imagine the wealth of information we have in there. But it's a bank of data and information, so it's as good as whatever you put in it, if that answers your question. It is reliable to the majority of it. If something gets missed or not, there is also, I believe, the ministry has taken over that whole thing in July of 2017 from the College of Pharmacists. So I'm assuming that now with the modernization of PharmaNet, things are being considered. But at this point, PharmaNet, in my opinion, is a very good tool for clinicians and pharmacists to look at the medication history, make decisions based on what they see. And as they say, it's the best known medication history.
Wondering if you could comment. I know historically PharmaNet does have the information about the pharmacist and pharmacy where the medication is dispensed, but the prescriber can't access that information. And often we would find that quite useful. So if we make a mistake, we can contact that pharmacy and communicate. Do you know about any plans to fix that so we can follow up with the pharmacist?
My understanding is that the identity of the pharmacy or the pharmacist who processed it is part of the privacy of the patient's privacy as well. So that's why we can't see each other. I can see, even as a pharmacist at a pharmacy setting, I can see a prescription is filled. I still have to call the help desk and get that information. And I had to give my name, my registration number with the college to get that information. I don't know what they're doing with modernization. However, there is a lot of work being done behind the scenes for a good PharmaNet to come down. How long is that going to be? I'm not sure.
We have a comment here says that doctor has a doctor line to call to see which pharmacy they are at.
Okay.
There's a help desk line that you can call, give your license, whatever registration with your college. That's how we do it as pharmacists.
Mm-hmm.
I can see that somebody got a prescription. I have to call the help desk on PharmaNet and give them my identifiers and whatnot. They'll give me that information.
Okay, that's good to know. Maybe that we can share that on the
Can
listservs.
you share with us this information and then we'll put it out for everyone?
The help desk?
Yeah.
I can, when I look it up, I'll send it to you.
Okay, great, thank you. One more.
Oh, good.
They said it is different than the pharmacist line. So can you please, person who commented, can you please let us know?
Yeah, email us about that, and then we will get that information and spread it out, because certainly that is a need. We hear these cases where, the doc or NP gives a prescription, and then an hour later they're thinking, oh my God, I forgot that they're on this too. I shouldn't have given that dose. I need to do something about it. But then they don't know which pharmacy they're going to. So we're trying to take control of that in Boost and have pharmacy information updated in our records. Yep. But this helpline would obviously be quite useful in those cases too.
Well, if you don't get a response, I will try and get you that answer as well.
Yeah, we have a number here.
Perfect.
Okay. The ministry has something called participation agreement with pharmacies, by which it's a contract between the ministry and the pharmacist about how they bill for methadone and what is it that they're allowed to do and what they're not allowed to do. One of the things that I saw in the list of questions was about the pharmacies and has the college had taken any action against pharmacies because of questionable practices or not. I'm only aware of one pharmacy that was questioned on practices this years ago. However, through the participation agreement, I know that the ministry had taken action against certain pharmacies that were not allowed to get participation agreement, which means that those pharmacies were not allowed to bill the ministry for any prescriptions they dispense, which could be very detrimental if your core clientele is paid by the ministry. However, this is the action that I know of that some pharmacies had to deal with. What happened after that and how those pharmacies came back to life, I'm assuming that those pharmacies had to meet certain threshold, and they met the qualifications to get their participation agreements. However, if you have any concerns about that, the ministry would be the best place to ask questions about anything that has to do with how this whole process of signing the participation agreement and how those pharmacies came to light. That puts the end for my slides. However, I'm here. I'm very happy to answer questions. Do you have any questions for me?
Let me just remind everyone that you have a question box over there. Please type in your questions. If you would like to ask a question, you can also wave your hand and we can unmute you and we can chat about it.
So, yeah, I think, obviously pharmacists are a key piece of this puzzle of trying to improve the care of our clients with opioid use disorder, keeping them on opioid agonist therapy, starting them on it. I'm kind of sad that we took so long to involve pharmacists, and we should have had you guys around from the beginning, and it's something we've learned, and hopefully we'll have more involvement for Boost 2.0. I guess, from a pharmacist perspective, what would you say would be important for us to do to keep people engaged in care, keep them on therapy? Do you see any kind of things that stick out where you think, oh, if the clinic did this, this patient would still be on therapy? Like if they communicated better the plan or made the script longer or anything?
Well, I'll tell you, through my fellowship now, I've been attending a clinic in Surrey, and I've learned so much in the time that I've spent there, and things that I didn't even, I had taken for granted. And I see that physicians really, or prescribers, but I work with physicians in that clinic. I don't have any interaction with nurse practitioners at this point. They do an excellent job accommodating the patient's needs and so on. I believe that the collaboration between pharmacists and prescribers can improve. There's always room for improvement. And like I said, pharmacists are a very good source for updates and what's happening with the patient, therapeutic progress, and so on. If we can develop that and work on it, I think that would be awesome for the patients.
Okay. I guess another thing I'm thinking of are these missed dose faxes. And well, what you're saying is, if people are going in every day and seeing the pharmacist, I feel like as a clinical team, sometimes we're not using that resource enough to see how the patient is doing. We may give a script and then they go a whole month. They see the pharmacist once a day and they see us once a month. We need to really be communicating, I think, better with the pharmacist to make sure, that they're going to notify us if anything.
Yeah, and if you're in the neighborhood, just drop by, come in, talk to the pharmacist. They'll be very happy to put a face to the name and put some reality checks here. Here's what I'm seeing, what are you seeing, and so on. Yeah. And pharmacists are a good source of information, and they always put the patient in the center of their conversation.
So I'm just looking at another comment here. So this says the ministry also has ownership requirements, and this is now under the College of Pharmacists of BC, including criminal record checks and requirements for pharmacy manager training because of the bad non-pharmacist owners.
The College of Pharmacists has a bylaw now of ownership, and the owners have to disclose, like the list of ownership has to be disclosed. In the past, any number of company could have been owner of the pharmacy. The requirement of the pharmacy, it has to do with the directors, not the ownership. At least that was the past, and we learned from that the majority of directors of a pharmacy must be pharmacists. But now with the new legislation, there is a committee that reviews the applications and to make sure that that the applicants or the owners meet the criteria that have been set for it. So yes, that's very true.
Okay.
I'm actually on that committee. Now that I think about it.
What about the issue of, as prescribers, if we do develop these relationships and know that, that here's a great pharmacist we have a personal relationship or professional relationship with, what are the rules for us then saying to other clients, hey, this pharmacy is good, you might want to check them out? I know there's been some advice that we can't do that. We can't give a list of preferred pharmacies and that whole idea.
Well, I know that, if you think about it, I think it's more of a perceived conflict of interest. That's about it. However, when you think about it in a perfect world, you should be able to work very closely with the pharmacy. I know that in the past, the College of Physicians didn't want physicians to put on the prescription, go to George's pharmacy or something like that. I don't know what changed there, or it has or it has not. However, it's mostly to make sure that you keep the relationship at an arm's length from any perceived conflict of interest.
Mm-hmm.
However, now that I think about it, I can tell you that when I was in community practice, one of the biggest challenge was for the pharmacist was to get hold of the prescriber. When there was a challenge, when there was a patient who had missed an appointment and the patient may need an emergency dose, and the pharmacist is doing their best to accommodate the patient or be understanding, but there's in the past, and I hope that has improved, and if it hasn't, here's a point. Prescribers may want to consider being more available to the pharmacist so that those issues get dealt with.
Mm-hmm, mm-hmm. And yeah, so I think some of our teams have actually done stuff that might help with that. I'm thinking of the South team who came up with a letter where if they're going to the pharmacy for the first time with a prescription, it gives them the pharmacist information on like phone numbers, what to do after hours, things like that. Yeah. So, having that information sounds like that would be useful.
I know from one of my friend's physicians out in Mission, she has regular meetings with the pharmacist in the area where she is. She calls a meeting with them and they discuss issues. And so, and I don't know how feasible that is in downtown Vancouver, but out in Mission, she's able to do that, and it seems to be working for her.
Yeah, I mean, the beauty of recording our pharmacy information in our EMR as well is we can quickly see who are our most popular pharmacies and then maybe target them for stuff like this and making the relationships better. What else? I have a lot of questions, so I'm just trying to think of the next one. Anybody else have any questions on the line here?
George, if I missed this point, excuse me, but then you said that the pharmacies are still using faxes, right?
Mm-hmm.
What can be an alternative, something manageable for both the pharmacy and the provider?
That I can't answer because I'm not here on a college capacity to see what other options they're looking at, because we're bound by privacy and so on. So whatever they decide, the means of communication that they decide to use, they have to meet those criteria. I don't know if the new PharmaNet will provide anything better like that, where direct communication through the PharmaNet itself. I'm hoping that would happen, but I don't know how soon that is going to happen. But in the meantime, yeah, they're still using faxes. I don't know if, I know that the whole world now is texting and Snapchatting.
Not
and
physicians still fax too.
Yeah, exactly. This has been well tested to know that we can use it for so many years. So I think we're comfortable within our settings for that.
Yes.
Questions?
So I think some of the pharmacies in the downtown east side for some of our teams are now creating a monthly missed dose report. Do you think the systems are set up so that if we requested that from our top pharmacies, that they would be able to create that with much trouble? Have you heard anything?
I haven't heard anything, but whatever report the pharmacy present has to meet certain criteria, including it has to be individual to the patient. It cannot be all the patients that missed in one piece of paper. And that's why if you were to authorize a refill on something, it has to be specific to the patient. It cannot be, here's a list of patients, give them everything.
Right.
That would not be legitimate.
Yeah, I think that's hopefully one of the improvements in PharmaNet will be that as a prescriber, I can go in and on one page see all of my clients who I've prescribed to, not open up patient by patient.
Well, I can tell you the modernization has been happening since '97. So.
How is
No, I'm lying. 2007. Sorry.
how open PharmaNet is to change? We can say, like, is there, how if the Boost teams would like to work with PharmaNet? Like, for instance, now I'm saying that can we change the faxing process because of privacy issues and maybe have it internally within PharmaNet? So how can we approach?
I think your easiest thing to do is talk to the College of Pharmacists. They're much closer than Victoria, and they can be the ones to kind of advise on what the next steps could be. College of Pharmacists is very open to other health care providers come to them with some ideas, but the ministry is now working on a big project, which is Prime, which is the whole gatekeeping of who's going to have access to PharmaNet. Once this is done, who knows what's going to be behind that door. But my advice would be to contact the College of Pharmacists, or if you want, I can help you set up something with the College of Pharmacists where you can have a direct line of what the challenges are and what they can do to help. The College of Pharmacists is also on a committee. So a working group has been struck between a few colleges of the prescribers. So the College of Nurses, or the BC College of Nursing Professionals, College of Pharmacists, dentists, vets, can't remember who else. They have formed a working group to review the whole control prescription program, the requirements of it. Should we be only limiting things to faxing or not? So this is all in the works. So again, like I said, and there's a representation from the ministry. So I think that would be your best bet, in my opinion, to reach out to the College of Pharmacists, because this is in the works. This is a very good time for you to kind of tap into it. They are looking for challenges, and so they can resolve them within the next steps.
Okay. I guess one other comment kind of echoing the privacy issues and also saying lawyers are doing the same thing. So it's not just the physicians and pharmacists
Doing what?
faxing.
Oh, yeah.
Yeah.
Faxing has been around for so long. It's just like, how comfortable are you with old medications? You're still describing cell phone.
One other thing that came up recently, actually, on the College of Physicians, their newsletter, it was about duplicate prescriptions and where you put the daily dose. So I think the way our prescriptions were being made, they had the drug name and then the daily dose in the top part.
Alphanumeric.
Yeah. So I guess there was a misinterpretation, and all 700 of Cadian was given on one day versus the 100 per day that it was supposed to be for 7 days. It looks like our EMR team has already moved the daily dose down to the instructions box on the duplicate. But can you comment on the requirements for including the strength in the top part, in the drug name and strength, when we're considering OAT? Because it's a bit difficult thinking about Suboxone, knowing it comes in 2s and 8s. We don't really want to have to, when I prescribe it, I don't want to write out Suboxone 2 this daily and then another prescription that says Suboxone 8 to do a total dose of 10. We just do Suboxone 10 milligrams per day and let the pharmacist interpret to give the strengths. Is that acceptable under the rules? I mean, it's what's being done, and I'm just wondering how that fits.
Well, as we go by the rules, the book of pharmacy says that the prescription has to include the drug name, the strength, the instructions for use, and so on. So that is what has to be done, because you also have to understand that pharmacists are bound by pharmacare audits. So if there is something missing, they could lose the money on the prescription. I'm not sure how your EMR works, but you're still using the duplicate prescription form, which has very defined sections of what each section is, the drug name and strength, it says, and then you've got the quantity.
So the way it works is we choose the OAT type from a drop down. So it just says methadone, Suboxone, or Cadian, and that's the drug name. And then the next box is just daily dose, because to us, the strength doesn't matter, right? It's the daily dose that matters. So, you know, this in practice has not been an issue, but just seeing this one thing come up where it was somehow misinterpreted, we're wondering about.
I think it's more of an odd one, because I'm not aware of anything like that. We usually, as pharmacists, we look at the total quantity, the daily dose, and we make sure that the math adds up, that the prescription will last for as many days as it is.
Okay.
So I'm really sorry to hear that this was missed.
Okay. And yes, just another comment here from another pharmacist that saying it is acceptable to just do the daily dose, and it's in one of the modules for prescription writing. Yeah.
So just like when you prescribe any other medications, you can always just put the quantity, like the daily dose, and that's just a simple math. So I don't know if that was just an odd case. Any other questions?
I think that's everything.
Perfect.
Yeah. So thanks to everybody who tuned in today, and thanks for coming.
Thank you very much for having me, and happy to answer any questions. If you have any, I can always respond and email you.
You have the email, and in 1 hour you will receive an email from us. Please, if you have more questions for George, let us know. We'll forward them to George, and he's more than happy to answer.
Absolutely.
You'll be also sent a survey, so please just take a couple of minutes. Let us know your opinion, your feedback on the session. Thank you, everyone, for joining us. George, Cole, thank you so much.
Thank you very much for your time. Thank you for having me over.
Our pleasure.